to another episode of this interesting webinar that we keep having on Saturdays and Sunday under the aegis of Mumbai Hematology Group. This has been brought by our program director, who has been working very tirelessly behind the curtain to get all these stalwarts on board. And today, a warm welcome to Dr. Talha Bada as well. A word about Professor Dr. M.B. Agrawal. We know him pretty well. Teacher of teachers, a leading hematologist of the country. No need for an introduction. Recently, he has also been conferred the Dronacharya Award. But we love him because of his untiring support to the field of hematology by getting the best of the brain who have done original work in the field. So thank you, sir. And we are extremely proud that you have been bringing us tirelessly without much of a hassle, all these welcome stalwarts like Dr. Talha Bada. Over to you, sir.
You're muted, sir.
Yeah, thank you, Dr. Manoj, for those kind words. And good evening to one and all from India, and good afternoon, good morning to the people from the rest of the world. Today, our guest speaker is Dr. Talha Bada from Mayo Clinic Cancer Center, Florida. He will be lecturing on challenges in management of TP53 mutated AML, potential strategies to improve the outcome. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS for continuously supporting our academic activities. Yash Kalpesh and the team Perfect Square for their flawless management. Executive Committee of Mumbai Hematology Group for giving me the free hand for organizing these academic events. And of course, our guest speaker today, Dr. Talha Bada from Florida. All our discussants were themselves eminent hematologists and medical oncologists across the country. And you participants for sparing your Saturday evening, afternoon, or morning, depending upon which part of the world you belong to. And we have today participation from about 25 plus countries. Tomorrow morning at 11:30 a.m. Indian Standard Time, we have discussion on state-of-art management of thalassemia by Dr. Capellini. She's the master of the subject from Milan, Italy. Our discussants today, they've been put up alphabetically here. I'll very briefly introduce them to you. We have Dr. Sekar from Mumbai, Dr. Vora from Mumbai, Dr. Fahima from Prayagraj, Dr. Hamza Dalal from Mumbai, Dr. Hari Menon from Bangalore, Dr. Hita from Kozhikode, Colonel Dr. Kundan Mishra from Lucknow, Dr. Mona from Lucknow, Dr. Rifai from Calicut, Dr. Roshni from Jabalpur, Dr. Sachin Jadhav from Hyderabad, Dr. Shilpa Bhartia from Kolkata, Dr. Shilpa Prabhu from Bangalore, Dr. Sudhir Atri from Rohtak, Dr. Panda from Gurgaon, Dr. Varun Bafna from Kolhapur, and Dr. Yashwant Kashyap from Raipur. I don't have to introduce Dr. Talha Bada to all of you. You've heard him a couple of times during these webinars, and we've been very fortunate that he's accepted another invitation to deliver another masterly lecture today. He's Assistant Professor of Oncology, Division of Hematology and Medical Oncology at the prestigious Mayo Clinic Cancer Center, NCI Designation Comprehensive Cancer Center in Florida. His research interest is in acute leukemia and germline predisposition syndrome. His long-term goal is to understand the mechanism of clonal evolution of leukemia, develop innovative strategies to improve its clinical outcome. While treating patients with myeloid neoplasms, he developed strong interest in patients with DDX41 mutation-related germline predisposition syndrome. This was the first lecture he gave us during the series of our webinars. As a PI and co-investigator, he has worked on the research projects related to this mutation. Currently conducting studies to explore functionality of DDX41 variants to determine pathogenicity and single-cell sequencing to discover unique genetic and epigenetic events associated with disease progression in DDX41 mutated patients. He's also very actively involved in clinical trials in myeloid neoplasms, both at national and international level. And today, of course, he's going to speak on this very difficult subject of TP53 mutated AML strategies to improve the outcome. And everybody is very excited to understand the lifetime work that he has done in this field and what's new in the horizon. Well, thank you so much. I will stop here and hand over the dais to him.
Thank you so much, Dr. Agarwal, for the introduction, and thank you so much for the opportunity to present a lecture on TP53 mutated AML, which I have some strong interest in, have done some work on it. And although there isn't, as you might have known over the years, the excitement have come into phases with novel drugs to counter the challenge which is posed by this poor response disease. However, every now and then, when it comes to advanced phase of the trial, we tend to get a setback where we don't see much in offering apart from conventional therapies in subset of patients that can still improve outcome for this disease. However, over the period of time, over years, we have understand more about this disease, and now everyone is well aware that this is a distinct entity and should be treated differently and should be at least viewed differently when it comes to management. So, so this is the overview of today's presentation. We'll go over the disease biology and what we have learned about this disease.
Slides are not visible.
Slides not visible. Is it fine now?
Perfect now.
Yeah. So yeah, so we'll go over the overview of today's talk. We'll go over the disease biology, and where we will discuss the impact of allelic burden and outcome of this disease. There's been a lot of talk about the influence of allelic burden and outcome and response to various therapies. So we'll go over that first. Then we'll go over the prospective studies which have been done to evaluate outcome with novel combinations and a spectrum using conventional therapies, hypomethylating agent therapies, and some newer therapies, including. Can you still, slide is visible to you?
No, again, yeah, now we can see that.
Okay. Sorry for that. Then we'll discuss the outcome. As you know, the venetoclax has been the paradigm shift in management of AML, not only elderly, but also in younger individuals who have a poor phenotype. So we'll discuss context of and the challenges in the contemporary era with managing TP53 AML. Well, I'll share with you some real-world data on survival outcomes over the years for this disease and role of allogeneic stem cell transplant. It has been a controversial subject when it comes to TP53 AML. There's a school of thought that believes that there's a futility in performing transplant, where others still optimistic that we can salvage not all, but subset of patients who have a disease phenotype or have depth of depending on the depth of response to the treatment prior to transplant. And then I will share some take-home messages from the work which has been done for this disease. So the functional spectrum of TP53 in health state. So TP53 is as you know, it's located in 17p13, essential for cell cycle control. And not only it's regulate the genomic stability, cell cycle and proliferation, but also have role in innate and adaptive immunity. So when it comes to AML, it's the most frequently mutated gene across all cancers and is strongly associated with large structural and complex chromosome aberrations. Although overall, if you see the incidence is around 5 to 10% in AML, however, patients who are elderly and develop this AML from prior cytotoxic therapy exposure, or patients who have complex cytogenetics, the incidence is higher in the range of 30 to 40%, and with complex cytogenetics, more than 80% of individuals will have at some level of P53 mutation. Unfortunately, it's a poor prognostic marker and it has inadequate response to conventional chemotherapies. No matter how intensive chemotherapy you give to this patient, the challenges persist. So here the intensity doesn't matter much. It's the approach, how you treat these patients matter most in terms of individualizing and personalizing therapy when it comes to this disease. So there's been a lot of talk about P53-mutated AML that it should be treated differently and it should be not combined with other adverse risk AML, in which we have some better outcomes with newer therapies and we can salvage them better. For this group of disease, among the spectrum of pre-leukemic stage to leukemic stage, it qualifies itself as a distinct group. As per newer ICC 2022 classification, they've defined P53-mutated AML in two contexts, one in context of blast percentage and other in context of allelic burden and associated chromosome abnormalities. So as per ICC, if you have 0 to 9% myeloblast, it qualifies as an MDS. Recently, there's a lot of debate with a new category which has been proposed like MDS AML, in which bone marrow or peripheral blood showing myeloid blast around 10 to 19%. Before it used to qualify the pre-leukemic or MDS stage. But now, as we have seen, patients who have 10 to 19% blast, their behavior, response to therapy, and outcomes are comparable to oligoblastic AML. Now it's redefined MDS AML, in which patients have present with 10 to 19% blast. And overall, however, irrespective of the blast percentage, is distinct category and should be managed differently, as I've been mentioned. When it comes to allelic burden in allelic state, historically, people feel that if you have multiple hit TP53 mutation, like more than two or more TP53 mutation, or you have a high variant allele frequency with P53, like just 50% or more, they tends to have a adverse outcome overall across the myeloid neoplasm spectrum. Initially, the discussion started with a Bernard et al. Paper in Nature Communication, where they found that MDS patients who have multiple P53 mutation or P53 mutation associated complex cytogenetic tends to have an inferior outcome. And those who have a single hit, one P53 mutation with VAF less than 10%, they tends to behave like a wild type P53 mutation. So this story was carried to AML space also, but later on we learned that in patients with advanced MDS and AML, that doesn't hold true. Multi-hit or single hit doesn't have any differential impact on outcome response to therapy, because at advanced stage, they acquire new concurrent mutations that tends to negate the maybe a better prognostic impact of single hit P53 mutation. We'll learn about more in future slides. So with this, as you can see, two landmark papers have been published. One is by Bernard et al. In 2022, where it shows that patients who had a multi-hit P53 mutation, they tends to have a more associated complex cytogenetics versus single hit mutation. They tends to have a more concurrent somatic mutation. And individuals who have multi-hit in MDS, low-risk MDS, tends to have inferior outcome, as I mentioned. Later on, group studied the impact of allelic burden or single hit versus multi-hit P53 mutation in advanced MDS and AML. As you can see on this curve, there hasn't been much difference in outcome. And this study shows that advanced MDS and AML should be treated as a single entity in terms of enrollment in clinical trials and in terms of how we approach these patients, in terms of therapy we choose for inducing remission, intend to induce remission at this stage. Second, what they've noted that patients who had a single or multi-P53 mutation in advanced MDS AML tends to have a similar outcome. Taking forward, we did a real-world analysis for around 380 P53-mutated AML patients across 10 academic US sites. And what we have observed that single hit versus multi-hit mutation tends to have a similar dismal event-free survival and overall survival, and validating the earlier finding that compared to low-risk MDS in advanced disease, the allelic burden itself doesn't dictate outcome. They're like a lot of multifactorial, like most of these patients are present at advanced age. Most of these patients present when they are more frail with comorbidities. And acquisition of concurrent mutations also define resistance to conventional or novel therapies and impacting long-term outcome. So as you can see on these two plots, as I mentioned earlier, although the outcome has been dismal in advanced MDS and AML, but we have seen a distinct molecular profile in single hit versus multi-hit T3 mutation. Single hit T3 mutation defines as T3 with VAF 10% or more without associated complex cytogenetics or 17p13 deletion discovered by FISH or loss of heterozygosity. These patients are called single hit, whereas multi-hit are those who had P3 mutation with VAF 50% or more, or single T3 mutation with complex cytogenetics or 17p deletion, or you have multiple P3 mutation with variant allele frequency of 10% or more. So as I've told you that these patients advanced stage tends to have dismal outcome. But in terms of molecular profile, single hit P3 mutation tends to have more somatic concurrent mutation, as you can see here, compared to multi-hit P3 mutation that tends to have a lesser degree of concurrent somatic mutation, but are more associated with complex cytogenetics. So something to know. However, it doesn't affect the impact on treatment strategies and outcomes. So then, as I've mentioned, that you see more P3 mutation among patients who have therapeutic AML or had prior cytotoxic chemotherapy or radiotherapy. In terms of P3 mutated AML, in individuals who have a prior therapy and now define as therapy-related disease, they have some distinct characteristics that are slightly different than de novo AML. We did this collaboration with colleagues from Australia, in which we have found, as we have known earlier, that you see a higher percentage of AML patients in therapy-related AML with P3 mutation. Second, we did sequencing studies that showed the P3 mutation as the notion is that it's acquired with time. It doesn't acquire with time. It's the clone may be present at a level which is not detectable with our genomic sequencing techniques or karyotypic analysis. It expands or evolves after getting a cytotoxic hit. However, as I mentioned earlier, among individuals who have sorry for this. Am I back to the slide mode?
Yes, sir. Yes.
Yeah. So I was mentioning that variant allele frequency, there's some earlier study that suggests from group from MD Anderson that if you have a VAF of 40% or more, these patients tends to have an inferior outcome compared to VAF 40% or less. And VAF 40% or more tends to have a better outcome with intensive chemotherapy. Negating that, in our experience and other experiences, we didn't find an impact of VAF in predicting outcome in patients with advanced MDS and AML. Similarly, in this study, what we have found, if you have a VAF more than 10%, not 40%, that is predictive of inferior survival for therapy-related AML. However, individuals who have VAF less than 10% tends to have an outcome comparable to de novo AML. Having said that, as per ICC, variant allele frequency less than 10% doesn't qualifies you with a diagnosis of P3 myeloid neoplasm. So when it comes to conventional therapies, when you see younger individuals with P3 mutated AML, there is a instinct that we should treat them with intensive chemotherapy, and if they're eligible for bone marrow transplant, have a donor availability, take these patients to bone marrow transplant. But what we have learned over the years, for cytotoxic chemotherapy to work for this group of patients, you need to have an intact apoptosis mechanism. However, as we know, among individuals who have P3 mutation, their apoptic mechanism is impaired. So no matter how hard you hit them with cytotoxic DNA damaging therapies, the outcome remains dismal. Then as we utilize more hypomethylating agent therapies and epigenetic therapy, we have seen in published literature, prospective as well as retrospective studies, that hypomethylating agent based therapy tends to have a better outcome, no matter if these patients are younger or older compared to intensive chemotherapy, because of the nature of the disease. Later on, maybe like 6-7 years ago, CPX351, as you know, it's a liposomal combination of 3+7, with the notion that the cell membranes of these tumors are lipophilic. If you have a liposomal combination, it may have a better penetrance to myeloblast and tends to have a better response compared to conventional 3+7 chemotherapy. CPX, based on the pivotal trial, got approval for patients who had AML prior MDS or AML with MDS changes, or who have a therapeutic AML. As I mentioned earlier, in therapeutic AML, you tend to see higher percentage of TP53 mutation. However, contrary to the pivotal studies where it's shown individuals with secondary AML may respond better to this liposomal combination, retrospective analysis showed that in individuals with TP53 mutation, CPX doesn't give you the same response as you see in de novo or as you see in AML with MDS with wild type TP53 mutation. So, and we have learned over the years the HMA-based therapy showed comparable outcome to intensive chemotherapy. It doesn't define the relapse-free survival or overall survival. Then with the venetoclax era, which has transformed the outcome, specifically early AML, who tends to have an inferior survival and tends to have a very moderate response to low-intensity therapy such as HMA. BLA study which showed that individuals who are ineligible for intensive chemotherapy, venetoclax-based combination tends to improve their response rate from 10 to 20% to around 65 to 70%. Composite CR I'm talking about, as in translation improvement in overall survival close to 1.5 years. However, there's certain high-risk group of patients that continues to have a dismal outcome with ven and HMA plus therapy. As you can see from the forest plot here, individuals who have TP53 mutation in that cohort, the ven HMA based cytidine plus venetoclax combination doesn't translate into improving or favoring use this combination compared to HMA alone. Subsequently, a expert analysis from BLA study and phase 1B study of venetoclax plus aza or decitabine reviewed the outcome among individuals who have a TP53 mutation or adverse AML with complex cytogenetics. We've seen here, it doesn't transpire into improved survival, this combination, for certain high-risk group of patients, mainly those with TP53 mutation. Later on, when we looked at all the AML patients, specifically the adverse AML patients, doesn't have this similar improved outcome with venetoclax HMA combination. As you can see here on the researchers, mainly led by the Anderson group, Courtney Donato et al., they've shown, although you can see a transient improved remission rate among high-risk AML patients, those with complex cytogenetics, deletion 17p, which is a surrogate for TP53 mutation, or TP53 mutation seen by genomic sequencing techniques, you tend to have a remission, but these remission doesn't last long. As disease evolves, the clone evolves and become resistant to ven-based therapy. Similarly, a couple of years ago at ASH, a German group evaluated the outcome based on gene signature among individuals who receive venetoclax plus hypomethylating agent therapy. As you can see here, TP53 AML continues to have a dismal outcome. Although we have seen improved response rate, but the overall survival hasn't improved with venetoclax-based combination, as you mentioned. So taking this forward, we utilize our database, our real-world database, to see does it hold true in the real-world setting. What we have seen here, when you combine venetoclax with FYDase or aza for this particular risk group, you tend to see an improved response rate, but it doesn't translate into improved survival. So what we have learned that if you have an individual who is a eligible candidate for bone marrow transplant and who have a eligible donor and who have a high blast percentage, you may use venetoclax-based combination to achieve a remission and then bridge them to bone marrow transplant. However, on the other hand, if you have a frail 75, 80-year-old individual who has comorbidities and present to you with P3 mutation, and using combination of venetoclax with HMA may just end up in more toxicity compare or in contrast to improving their survival outcome or longevity. So this study doesn't mean that you shouldn't be using this combination in individuals who may be down the road candidate for bone marrow transplant, but in a failed elderly AML patients, we have seen more morbidity and mortality with this combination. Second, for this particular phenotype, we haven't seen much improvement in overall survival. So there always been a talk that P53 mutated AML tends to have a more immune-rich phenotype or immune-infiltrated phenotype. And there's some preclinical and clinical studies in which expert analysis suggests that they have a higher expression of PDL1 and CTLA4. So there's always a thought that immune-based therapy may work better for this group of patients. So we conducted an investigator-initiated study in which we utilized CyTOF, which is a more specialized flow cytometry technique we call like mass cytometry, in which you can better understand a clonal architecture of AML and how it evolves with time compared to conventional immunophenotyping techniques such as flow cytometry, in which you, like, for example, flow cytometry can be a 7-color, 10-color, 12-color, but with this site of analysis, you can have a detailed evaluation or clonal evolution pattern for patients with myeloid neoplasm. So we conducted this study in which we have taken baseline peripheral blood and bone marrow samples on patients who are receiving venetoclax plus HMA-based therapy and try to understand their immune profile or baseline T cell profile. With utilizing CyTOF time of flight cytometry technique, we created 35 clusters, rhenograph clusters, T cell rich clusters. And interestingly, what we have observed, validating the earlier studies in which P53 AML tends to have a more T cell rich phenotype with higher expression of NK cells, CD4 effector cells, and CD8 cytotoxic T cells. And then, however, this didn't translate improvement in outcome when these patients with highly immunogenic phenotype receive venetoclax plus HMA-based therapy. Hypothesis is that these patients, if combination with immune-based approach, may have a better outcome for not all the P53 AML patients, but those who have a more immune-rich phenotype. Interestingly, among this cohort of 26 patients, those who showed a distinctly significant T cell infilled phenotype, all of these patients had a multi-hit P53 mutation. So as I mentioned that there's the notion that P53 AML or we are convinced that these patients have a more immune-infiltrated phenotype. So immune-based therapies have been tried for this poor prognostic disease in order to improve outcome. There is some preclinical data in vitro studies that showed that increased PD-1 expression has been found, and which is linked to immune evasion or immune senescence when these patients developed AML. Initial studies in relapsed refractory as well as treatment naive group, nivo or pembrolizumab combination with HMA or intensive chemotherapy showed comparable responses in phase 2 studies. Later on, the MEGRO anti-CD47 serum alpha fusion protein inhibitor phase 2 study that you all know has shown promising results with remission rate close to 60% in 1 year survival, close to 70-80% when magrolimab combined with Vidasa or Vidasa plus venetoclax combination. And we all were very excited with the phase 3 study, ENHANCE 2 and ENHANCE 3, but we have learned a few months ago that this program was shut down due to fertility, as we have seen more toxicity with this magro-based combination, more commonly the hemolytic issue with this drug. Now there are different fusion proteins being evaluated in clinical trials, which may not have similar degree of adverse effects such as hemolysis and being evaluated in clinical trial, but that is a sad story. So, as I mentioned earlier, the immune-based combinations doesn't pan out to be an effective therapy. However, there are initial studies which showed some promising results. This table shows the prospective studies over the last 2 decades, including patients who had TP53 mutation. As you can see here, in some of these studies, such as 10 days decitabine, that was a big breakthrough. This paper published in NEJM among individuals who had TP53 mutation tends to have 100% response rate with 10 days of decitabine with comparable overall survival. Later, other groups have a analysis in which they compare 5 days versus 10 days decitabine on a bigger cohort of patients couldn't replicate the finding which were earlier presented by a group from Washington University. Later on, Videsa plus Ven versus Videsa alone, as I mentioned earlier, doesn't transpire to improving outcome for this group of patients. Fritizumab, which is a bispecific CD33 targeting antibody, in subset of patients, it did show improvement in response rate with single agent therapy around 47% among individuals with TP53 mutation. However, it didn't translate into improving overall survival. APR or epineptide, which restores the wild type TP53 in combination with Videsa in earlier studies shown encouraging response rate, mainly in MDS patients and some in AML patients. The phase 3 study was shut down due to futility. As I mentioned earlier, sabatolimab and magrolimab, the story is also unfortunately didn't pan out to improve outcome for this group of patients. So with this in mind, we conducted a real-world study and tried to see the trend, the physician perspective and trend, how this disease should be treated, which has changed over time. As you can see here on the top figure, the green bar shows the increased utility of venetoclax-based therapy for this group of patients for 2 reasons. One, the intensive chemotherapy doesn't always translate into improved outcome. Second, most of these patients are elderly and prior therapy-related AML, and most commonly they tend to have this disease. And third, they may not be eligible for intensive chemotherapy. But what we have seen, although the venetoclax-based therapy tends to show a increased trend utilization, but it didn't translate into improved survival. The survival for this group of patients, no matter intensive versus non-intensive or novel therapies, remains to be 6 to 9 months. However, in multivariate analysis, what we observe, the single factor that is shown to favor improve their long-term outcome was oldest form of immunotherapy, that is allogeneic stem cell transplant. I don't know how I did this. I don't know how to correct it. Yeah, I think it's corrected. Sorry for that. Yeah, so role of bone marrow transplant. As I mentioned earlier, bone marrow transplant for adverse AML has always been known to be a potential curative strategy to improve long-term outcome for this group of patients. When it comes to TP53, there are some reservations among transplanters that we should transplant these patients or don't transplant these patients. But we do offer these transplants, especially in younger individuals, to improve their long-term outcome. Factors that have shown to impact outcome in general, and for this adverse risk group of patients, is concurrent somatic mutation, complex cytogenetics presence at the time of diagnosis, and certain variant type. Most of TP53 mutated AML patients have a missense mutation, and some of them have truncating mutations. Truncating mutations tends to have an inferior survival compared to missense mutation. Depth of response prior to transplant also dictate outcome in general in all comers, and similarly so in TP53 AML patients. Conditioning intensity, there's a thought, if you give individual a myeloablative conditioning, it tends to improve the overall survival. However, it can cause more morbidity, especially in elder individuals. And post-transplant strategy. There are some phase 2 data that suggest HMA-based therapy, other novel therapies may improve the relapse-free survival, but randomized studies didn't pan out specifically that any maintenance therapy in adverse risk AML tends to have a favorable outcome compared to observation. So when it comes to P3 mutation, there have been a lot of studies done evaluating the condition intensity, the presence of complex cytogenetics or not. One of them was studied by European BMT group, in which they found that condition intensity for this group of patients doesn't translate into better or worse outcome. But individuals who have complex cytogenetics with TP53 mutation tends to have inferior overall survival, 2-year overall survival around 24.6% versus 65.2%. Those with TP53 mutation and doesn't have a complex cytogenetics. As I mentioned, the post-allo maintenance, we always discourage when we see early relapses in adverse risk AML patients. So there is some studies in which the decitabine was combined to G-CSF or preemptive DLI to have a better GVL effect, and Videsa have been used. However, the phase 2 study on the top of this slide showing that randomized study didn't show, although we have seen improvement in relapse-free survival 2 years compared to 1.2 year. However, it wasn't significant. Similarly, the APR-246 combination with Videsa utilized among TP53-mutated AML patients to improve the relapse-free survival post-allo. The initial study, the phase 2 study, was encouraging. However, this program wasn't pursued further in a randomized fashion, as I told you earlier, due to fertility. So we don't know if the APR combination will improve outcome or not for this group of patients. As I mentioned, the immunotherapy, we believe that whenever cancer occurs, our immune mechanism, the cancer escapes the immune mechanism and immune exhaustion, senescence or immune evasion occur, and then the individual develop cancer. As I mentioned, transplant has been the oldest form of immunotherapy and tends to salvage around 40% of patients with adverse and high-risk AML. This approach, preemptive DLI, has been tried to have a better GVL effect among high-risk MDS and AML patients, with improvement in 2-year survival in 65.2% in earlier phase studies. This study hasn't specifically evaluated TP53-mutated AML patients, but that is one of the strategies which has been evaluated using the immunogenicity to overcome the adverse risk phenotype. Utilizing our real-world data, since there have been conflicting reports, we just evaluated those individuals who receive bone marrow transplant among 380 AML patients. What we have seen, although the number of individuals who receive bone marrow transplant after first remission or second remission were very small, around 15 to 20% of those. But among those individuals who receive bone marrow transplant, we have seen significantly improvement in event-free survival and overall survival. As I was shown you in all comers, the overall survival for this size group of patients, no matter what kind of treatment you pursue, is around 6 to 9 months. But with this group of patients, you can see the event-free survival with BMT after first line or second line therapy was way better than non-transplant approaches. And this also translated into improvement in overall survival. As you can see here, the median overall survival when BMT was pursued in a subset of patients were around close to 3 years. In individuals who received transplant after induction in CR1 versus those who received transplant in CR2 had close to 2-year overall survival. So that suggests that transplant still have a role. It may not be a magic thing for all comers with TP53 mutation, but certain subset of patients can still have an improvement outcome in contemporary era. Then we look at the univariate and multivariate analysis. What are the predictors in which dictates that individuals who have TP53 mutation tends to have a better outcome? What we observe, individuals who maintain remission at day 100 post-allo and who develop chronic GVHD tends to have a better event-free survival and overall survival. As I've mentioned earlier, probably the graph is leukemia effect. As we have seen in most of the little bit of GVHD is always beneficial in sustaining remission and improving the event-free and relapse-free survival. We've also seen individuals who had some chronic GVHD or who maintain remission at day 100 post-transplant tends to have better survival. As earlier studies, we haven't seen the intensity of conditioning significantly impacting their survival outcome. We haven't seen, although the number is very small, but we haven't seen a maintenance therapy strategy tends to favor the improvement in event-free survival and overall survival, as have been shown in earlier studies. And this is the curves among individuals who maintained remission at day 100 post-transplant or who develop GVHD. As you can see here, those who develop chronic GVHD, their event-free survival was close to 2 years and overall survival close to 4 years. So that is very impressive. But these are very small subset of patients. Still, the P53 mutation AML tends to have inferior outcome, but this is the oldest form of immunotherapy that still shows some promise to treat this high-risk disease. So take-home message from today's discussion. First, P53 AML patients is increasingly recognized as a distinct entity with poor outcome. The notion that allelic burden dictates outcome is not holds true with advanced MDS and AML. All these patients tend to have an inferior outcome and doesn't suggest which type of chemotherapy induction we should use. And we're still searching for a novel therapy that improve outcome for this group of patients. Venetoclax-based therapy does improve the response rate, the composite CR rate for this group of patients, but doesn't improve the overall survival. So if you have a frail patient with this mutation, venetoclax plus HMA combination may not be a wise thing to do, may end up in morbidity. Data still suggests that bone marrow transplant is one factor that can salvage a small subset of patients. Novel treatment combination, a better patient selection, and recognizing the resistant mechanism that develop with passage of time may help in identifying a therapy that tends to have a durable response for this poor prognostic disease. With this, thank you for listening.
Thank you, Dr. Talabadar, for that wonderful review of this subject and your research. And we will have some questions from the audience. Can I start the first one? Is it okay that in 2024, we should put all the patients on HMA with venetoclax and whoever is transplant eligible, subject them to transplant so that at least those small fractions can be saved?
Yeah, as I mentioned, if you have an individual with have comorbidities and you are not looking with an eye that this individual should receive transplant, maybe HMA venetoclax combination for this subgroup may not be a wise idea. But if you're thinking to take these patients to transplant and you're hoping that we can improve outcome, then definitely HMA venetoclax is better than intensive chemotherapy, or high dose cytidine-based chemotherapy.
Right. So we'll take questions from, yes, Dr. Roshni, your question.
Good evening, sir. Thank you for that excellent talk. First question is, should germline testing be done for all patients irrespective of the TP53 VAF, or is there a cutoff percentage for doing germline testing?
So you can stop sharing your screen.
Yes. So germline testing for P53 mutation, you can do germline testing for when you see a younger individuals for this mutation. When you see someone who are elderly or who had a prior chemotherapy or cytotoxic therapy and developed AML with P53 mutation, then germline testing may not be a viable option. We assume that if you have a VAF in majority of the germline participant syndrome, that if you have a VAF more than 40%, these are most likely germline. But if the history doesn't suggest that these patients are Lee-Fromani syndrome or something like that, then I don't think germline has a value for this group of patients. But if you see a younger individual like 18, 19-year-old ALL or AML with P53 mutation, then definitely germline testing and getting a better history, a family history, to look for oncological history among siblings and close relatives is important.
The second question is, sometimes people do ask that should genetic testing be done if you have an index case of AML? So should we be offering genetic testing for family members with AML, with a patient of AML?
Thank you. There's certain mutation that have a germline Prism syndrome, such as those with DDX41 mutation. If you find a DDX41 mutation, then definitely you should screen the family and do germline testing. If you have a GATA1, GATA2 mutation, in those individual germline testing at earlier age is beneficial. But so specifically in specific mutation, then you should need to SH2B3 is another germline mutation. If you find a myeloneoplasm, you should do germline testing, but not in all comers. A specific mutation within have known to have a GPS or Piston syndrome, germline testing is indicated.
And how do you all screen the donors before the transplant? Do you also do the TP53?
Generally, there's a more and more belief that if you have a elderly sibling, you better find an unrelated donor or a haplo rather than getting an elderly sibling. But these patients may have like a pre-leukemic stage or MDS, or they have some clone hematopoiesis that can lead to a suboptimal outcome. If you have a DDX41 mutated AML patient, then definitely you shouldn't be using their sibling as a donor or other germline Prism syndrome. There are still some centers who believe that elderly individual can be a donor, a sibling donor, but there are more and more studies which we have participated also that younger individual unrelated donor is better than match-related elderly donor.
And is it okay to say that in a frail elderly, best supportive care may be better than Azaven?
Yes, I agree. Goals of care discussion should always be done, and frankly and honestly should tell them like what we are looking for in next 6 to 8 months. If you'd like to pursue life prolonging therapies, maybe low intensity therapy better, or supportive care. Like we all believe that P53 AML, nothing works and people die, but that doesn't mean that we should forego treating these patients to improve their longevity. Low dose hypomethylating therapy such as 3 days, Y-days, or decitabine have used in high risk MDS and AML patients, which has improved their outcome to 1.5 years or so in certain cases. So case to case basis, best supportive care may be an option only for some individuals, but some low intensity therapy or some clinical trial participation should be considered in other cases.
Thank you so much.
Thank you, Dr. Roshni. We'll take one question from the audience. Dr. Amber wants to know if there's a younger patient, will you still give HMA venetoclax or they will be candidate for intensive chemotherapy?
Yeah, I would prefer, what I have been preferring is venetoclax-based therapy in younger individuals. I haven't used intensive chemotherapy because haven't seen much success. There is few upcoming trials in which they have combined the intensive chemotherapy with venetoclax, like group from MD Anderson conducted a study with FLAG IDA-Ven. However, in their multivariate analysis, the only factor that predicted inferior outcome was those with P53 mutation. So intensive chemotherapy doesn't really work. HMA-Ven combination and bridging these patients, eligible patients for transplant, is still, I think, a wise strategy or a clinical trial participation.
Thank you. Dr. Tribikram.
Thank you, sir, for your comprehensive review. So, sir, actually, my question is, yes, you have already told how to choose patients for eligibility for stem cell transplantation. So, what is your optimal method of MRD detection? How do you detect pre-transplant MRD at your center, apart from flow, before taking a patient to transplant?
Yeah, so the MRD in AML, It's still debatable.
Yes, okay. Okay, please.
Yeah, I was saying that MRD is not as well defined in AML as it is well defined in ALL. So there's always a debate that its MRD holds value in AML. The flow cytometry based MRD, I still believe is inferior. But if you have a stable molecular marker, that should be used in MRD, like an NPM1. Nowadays, there's a better marker to identify like FLT3 ITD that should be used. Or a molecular marker is better predictive outcome when it comes to AML rather than conventional immunophenotyping techniques for particularly AML. And now there's more talk about NGS-based MRD in ALL as well as AML. But I would say stable molecular mutation is better utilized for MRD detection AML compared to conventional immunophenotyping.
So coming to the role of post-transplant optimization, so do you give injectable azacitidine or oral azacitidine? With oral azacitidine maintenance with DLI, of course. So what is your experience?
So post-transplant maintenance, as I mentioned, the randomized study of ideas versus observation didn't show much outcome. There's a phase 2 study in which we have used cytidine plus GCSF, post-transplant as maintenance strategy in high-risk AML patient and DS patient that has shown some benefit. There is a currently study conducted by transplant CTN, which they modified dose by days of plus D post-transplant for like reality study. We anxiously wait for the outcome of that study to
Sorry,
suggest
your
that.
voice is not audible. It's not clear. Hello?
Can you hear me now?
No, sir, suddenly your voice has become indistinct. Closer to
Yes.
the mic, maybe.
So I think it's a background noise from someone called SA. The background noise that is mumbling. Yes, now it's clear. Yeah.
Can you hear me now?
Yes, sir.
Yes, sir.
Yes. So I was saying, this is a captain view, like from the so I mean, so the maintenance strategy post-transplant high-risk AML patient still needs to be further explored. We don't know what maintenance strategy work best. As I mentioned, Videsa plus venetoclax is being investigated prospectively as a maintenance strategy for high-risk AML patients. Menin inhibitors has been evaluated as a maintenance strategy. FLT3 maintenance has been well established for this FLT3-mutated AML patient with quizartinib as well as midostaurin, but specifically non-targetable mutation, high-risk AML patient maintenance strategy is still under investigation.
Sir, would you like to give injectable azacitidine or oral azacitidine for TP53 mutated AML
Yeah,
transplanted?
so the oral azacitidine formulation, uh, we don't use apart from those individuals who are in remission and transplant ineligible. We give a sub-Q or IV azacitidine. We do have oral decitabine and IV decitabine that can be used.
Okay, sir. Okay, thank you, sir.
Thank you. Dr. Fahima?
Very elegant talk, Dr. Talha. Thoroughly enjoyed it. I have just a single simple question. So the demography in our country of AML is pretty different. And, we don't see very old with TP53. In my experience, we see usually 40 to 50 male with increased incidence of TP53 mutated AML. So it is very difficult to always convince people to go for, supportive care. And we know the prognosis. Which exact group of patients would you push for HMA when followed by a transplant? Can you just enumerate it so that it will be easy for us? And how do you actually prognosticate the other TP53 patients with VAF more than 10% and other complex cytogenetics? Even you put them only on best supportive care, or you still go ahead with HMA when despite not proven OS benefit in the absence of a matched sibling donor or unwillingness for an allo transplant?
Yeah, that's a very good question. So if you have a younger individuals who seems to be transplant eligible, I think HMA venetoclax-based therapy and start workup of donor search and take them to tissue transplant is important. One thing in generally, even in US, what we lack is sometimes when we see these myelosuppression post venetoclax-based therapy, people immaturely stop venetoclax. Let's say they will give venetoclax for initial month with HMA, and then there's a prolonged myelosuppression, and they wait for 3 months for the counts to recover, and then they pursue a second cycle of NHMA, which is not right. I don't think 28 days of venetoclax is the right strategy. Maybe 21 days venetoclax and bone marrow biopsy is important. Then if you see in a hypocellular marrow, you give them GCSF to improve the neutrophil count and pursue next cycle with a shorter duration of venetoclax rather than holding treatment prematurely or delaying treatment for 2 months. The second caveat we have seen, while I see a patient with previously mutated AML patient, I give NHMA, they achieve remission, I send to a transplant physician, and this individual didn't receive transplant for 3 months due to various reasons, X, Y, Z. These patients, if you don't continue some form of chemotherapy, ven-based therapy, while you take them to these transplant, if you have a 2 months bridge, the disease will evolve and you have a bad outcome. So these two strategy, unnecessary delay, unnecessary dose reduction is not recommended. You should take these patients to transplant as soon as possible protectively. So I will use VNHMA based therapy for this group of patients. If you have a 65-year-old or 70-year-old with diabetic, with ECOG of a measure of 2 to 3, and you don't see him or her as a transplant candidate, then HMA based therapy is still can improve the longevity compared to best supportive care, and you can always modify to a 3-day regimen if 5-day or 7-day regimen of decitabine or YDs are respectively it doesn't look practical. And if you have uh, one thing more which we have seen prior to transplant, if you see that the bone marrow biopsy prior to transplant, you have eradicated the complex cytogenetics and going into transplant with P3 mutation, they tends to have a better outcome. But if you see still high metaphases of adverse phenotype, monosomal karyotype, then these individuals may need some more therapy prior to transplant.
Thank you. Thank you so much, doctor.
Thank you, Dr. Faima. We'll take a question from the audience. Dr. Salish wants to know about patients who relapse after stem cell transplant. What do you do?
Yeah, I will pray for them. So relapse post transplant for this group of patient is very, very challenging. What has seems to benefit in certain subset of patients which I have done is a regimen, a low intensity regimen called cladribine low dose RC plus venetoclax. It's from Tapan Kadia from MD Anderson has this paper like in relapse refractory and upfront setting. So I've used that, and after clearance of blast, I've given DLI on these individuals. So I've seen an improvement around 9 months or a year in certain subset of patients. So that is a strategy you can pursue post-transplant relapse. If they haven't seen venetoclax before, then HMA-VEN and DLI. People believe some school of thought that DLI is equivalent to second transplant. So post-transplant relapse, looking at their chimerism, if you give some chemotherapy for clearance of the disease and do DLI after every 2 to 3 months, you may prolong their life expectancy. Second thing is when you have a relapse post-transplant, disease phenotype may change. So looking for targetable mutation is always a wide strategy. Uh, if you want to be very economical and rationalized, you can look for certain mutation IDH1, IDH2, or FLT3, because some individuals may have a disease phenotype. There's a rare chance you can find some target that you can uh, use it against.
Thank you. One more question from the audience. Dr. Kiran wants to know TP53 mutated AML with FLT3 ITD mutation.
Yeah, that's a very good question. So I looked at my database. There are very few patients who have a targetable mutation with P53. But I will definitely use a FLT3 target in combination with HMA or venetoclax rather than giving intensive chemotherapy for this group of patient. One thing I've recently seen, there's a very small subset of patients with IDH1 mutation with P53 mutation. This paper, a recent paper, is accepted in Hematologica. So that group of patient tends to have a better outcome. If you have a P53 with IDH1 mutation, I've seen that these patients have lesser chance of secondary AML, lesser chance of complex cytogenetics, and they respond better with venetoclax-based therapy compared to those who are IDH1 wild type.
Thank you. Dr. S.A., your question.
Sir, good evening. I have comments and a question. Comments regarding the oral versus the subcutaneous or IV as a maintenance therapy. Sir, oral is more amitogenic as asked by Dr. Tribhuvan Panda. So many of the patients are not able to tolerate the oral azacitidine. So preferably it should be given by the parenteral route, even in maintenance therapy actually, sir. That was my comments. And regarding the question, sir, intensive chemotherapy, 3+7 flag ida, which is preferred for such patients actually.
I don't think there's a randomized comparison. High dose cytarabine may be better than 3+7 if you want to choose, but I've been telling like intensive chemotherapy doesn't pan out well. So I will err towards venetoclax-based therapy if it is available. If not,
Okay.
then yeah.
Okay. Thank you.
Is an unusual question from the audience. Dr. Vivek Mohan wants to know that if the blasts are CD20 or CD38 positive, can you use obinutuzumab, rituximab, daratumumab as maintenance therapy?
So I haven't seen a case where you find a CD20 positivity in myeloid. You do see a CD38, which is readily expressed in myeloid neoplasm. So we participated in an investigator-initiated trial, a phase 1 trial using bispecific CD3, CD38 antibody. We haven't seen much success yet. Daratumumab have been tried in leukemia world and myeloma world. I haven't come across a study in myeloid world which have been tried. So CD20 I haven't seen, CD38 I've seen with limited efficacy targeting CD38 in myeloid malignancy.
Right. So that's the last question from the audience. Anyone over here wants to ask anything to Dr. Vada? Okay, if not, then sir, thank you so much. You spared your very valuable time and updated us with this very difficult disease to treat. And at least we have become very clear about what the approach in the Western world is. And definitely the patients on this side of the world will benefit from your talk today. Extremely grateful to you for doing this for us. Thank you.
Thank you so much. Thank you so much for invitation. I really enjoyed the discussion, and yeah, pleasure.
Thank you. Bye-bye. Have a wonderful.
Thank you. Bye. You
Bye.
too. Thank you.